I'm excited to welcome you to this presentation on barbiturates, covering their fascinating history, medical uses, pharmacology, and the important topic of misuse. As you can see from the vintage laboratory image behind me, we'll start back in the 19th century, exploring how these compounds were first discovered and developed. From there, we'll trace their journey through clinical applications and discuss both their benefits and risks. Let's dive in and uncover the story of barbiturates together. Anxiety and insomnia have been persistent challenges throughout human history. Traditionally, people often turned to alcohol as a way to cope with these issues, although it wasn't a safe or effective solution. Today, we're seeing a concerning global increase in both anxiety and insomnia cases. In fact, during the COVID-19 pandemic, the prevalence rose by about 25%, highlighting just how impactful recent events have been on mental health. The image here of a person lying awake at 4:24 in the morning captures the restless, isolated experience many face, underscoring the urgent need for safer and more effective treatments beyond historical approaches. Here we see some of the earliest treatments used to manage anxiety and insomnia before barbiturates came onto the scene. First, chloral hydrate was introduced around 1870 as a hypnotic agent. It could induce sleep fairly quickly, lasting up to 11 hours, but it had significant downsides, particularly stomach irritation and a high potential for addiction, all within a narrow safety margin. Next, formaldehyde came into use in 1882 as a hypnotic that was effective with less risk of respiratory depression. However, its very strong and unpleasant taste, along with a distinct breath odor, made it less tolerable. Moreover, its potential for misuse was quite similar to alcohol. Finally, bromide salts were introduced in the mid-1800s primarily for epilepsy and sedative purposes. Unfortunately, these compounds tended to accumulate in the body, leading to toxic effects and severe withdrawal symptoms like seizures and delirium, which severely limited their safe use. Looking at these early treatments, you can see the balance clinicians had to strike between effectiveness and safety, and they highlight the challenges faced in developing safer medications for anxiety and insomnia. The image here reminds us of those early apothecaries where such remedies were first dispensed. Here we have a timeline that traces the development of barbiturates, starting with the discovery of barbituric acid back in 1864 by Adolf von Baeyer. This was a significant breakthrough because it laid the chemical foundation for an entirely new class of compounds. Moving forward to 1903, we see the introduction of barbitol, which was the first barbiturate to be used clinically. This marked an important milestone as it opened the door for medical applications of these compounds. By the mid-20th century, barbiturate production had reached its peak, with over 2,500 different compounds developed. However, only about 50 of these were actually used in clinical practice. This was largely due to the unique chemical structure of barbituric acid, which allowed for countless derivatives to be synthesized, but not all had practical or safe medical use. Interestingly, during this period, barbiturates were initially believed to be non-addictive, a misconception that influenced their widespread use. Overall, this slide highlights how the chemical foundation led to rapid development and clinical adoption, setting the stage for both the benefits and challenges associated with barbiturates. Here we have a closer look at how barbiturates interact with the brain, specifically through their effects on the GABA receptor complex. The chart compares two types, pentobarbital and phenobarbital, focusing on lipid solubility, onset of action, and duration of effect. You can see that pentobarbital has much higher lipid solubility, which means it crosses the blood-brain barrier more quickly, leading to a faster onset of action. However, its effects don't last as long, with a shorter duration compared to phenobarbital. Phenobarbital is less lipid soluble, so it acts slower but stays active much longer. What's crucial here is understanding that barbiturates can directly activate the GABA receptor even without GABA present, unlike benzodiazepines that only enhance GABA's effect. This direct activation explains why barbiturates carry a higher risk of overdose and respiratory depression. This fundamental difference highlights why they must be used with great caution despite their clinical benefits. Barbiturates, while not as commonly used as they once were, still have specific and important roles in clinical practice today. Firstly, They are sometimes employed for anesthesia induction in brief surgical procedures, helping to prepare patients for surgery efficiently. In seizure control, certain barbiturates like phenobarbital remain valuable for managing specific types of epilepsy that may not respond well to other treatments. They are also used in treating some forms of migraine headaches, providing relief when other medications might not be effective. Lastly, barbiturates can be important in managing alcohol withdrawal, especially when benzodiazepines are either ineffective or unavailable. It's worth noting that due to their potential for abuse and side effects, barbiturate use is highly regulated and reserved for these specialized situations. This explains why, despite their decline, they continue to have a place in modern medicine. Barbiturate use comes with a variety of side effects and potential complications that are important to be aware of. Starting with sedation and drowsiness, barbiturates produce a calming and sleep-inducing effect similar to alcohol at therapeutic doses. This is often the primary reason they're prescribed, but it can also impair daily functioning. Next, barbiturates suppress REM sleep, which disrupts normal sleep cycles. When patients stop taking the drug, they may experience intense rebound dreams as the body tries to compensate for this disrupted sleep pattern. Another issue is the drug hangover effect. Because barbiturates have extended half-lives, they tend to stay in the system longer, causing prolonged impairment in motor coordination and judgment even after their main effects wear off. Common side effects also include feelings of nausea and dizziness, which can affect patients even at regular doses. Some patients may develop photosensitivity, a heightened sensitivity to sunlight that increases the risk of sunburns after only brief exposure. This is a less common but significant concern. Finally, long-term use can lead to more serious complications such as cognitive decline, reducing mental sharpness over time. It can also negatively impact sexual health, causing reduced libido, performance issues, and even paradoxical rage reactions. Understanding these side effects is crucial for safe prescribing and effective patient counseling, helping to balance therapeutic benefits with potential risks. Here, we focus on the misuse potential and patterns of barbiturate abuse. Starting with geographic seizure patterns, the majority of barbiturate seizures come from the United States, with moderate reports from countries like Indonesia, Canada, and Australia. This highlights where these substances are most commonly intercepted. On the other hand, when we look at common misuse behaviors, users often escalate their doses over time, which increases risk significantly. They also tend to combine barbiturates with other central nervous system depressants, such as alcohol, further compounding the danger. Additionally, illicit manufacturing and distribution remain ongoing issues. The large red stop button image serves as a strong reminder of the serious risks, including a high overdose potential historically linked with barbiturate abuse. Understanding these patterns and behaviors is crucial as we consider strategies to address and prevent misuse. Barbiturate withdrawal poses significant risks that require careful and immediate attention. Typically, seizures can begin as soon as 2 to 3 days after stopping the drug, and the most intense withdrawal phase can last anywhere from 3 to 14 days. Alongside seizures, patients may experience muscle weakness, tremors, heightened anxiety, agitation, and even delirium tremens-like symptoms. Another notable feature is REM rebound, which leads to intense and vivid dreams during withdrawal. Because of these serious and potentially life-threatening symptoms, management must take place under strict medical supervision, ideally in a 24-hour monitored setting. A gradual reduction of the barbiturate dose is essential to minimize risks. In many cases, doctors use long-acting barbiturates, such as phenobarbital, to help stabilize patients and smooth the withdrawal process. This approach significantly reduces the chance of complications while ensuring patient safety. The image here illustrates the clinical environment necessary for this kind of supervision, highlighting the continuous monitoring and attentive care patients must receive. Proper management is not just beneficial, it's vital for a safe and effective recovery from barbiturate dependence. Here we have an overview of barbiturate-like drugs that were developed as alternatives to barbiturates but brought their own set of issues. First, meprobamate was introduced in 1955 as both a daytime anxiolytic and a nighttime hypnotic. It was initially thought to be non-addictive, but it soon became clear that it had significant addiction potential. Moving on to methaqualone, better known as Quaaludes, it was marketed in the 1960s as a safer alternative. However, people quickly developed tolerance, and its euphoric effects led to widespread misuse. This ultimately caused it to be withdrawn from the US market. Lastly, glutathione and ethchlorvanol were introduced as barbiturate substitutes as well, but they caused severe withdrawal symptoms and carried overdose risks. Because of these concerns, their use today is very limited and cautious. Although these drugs were initially promising, they share many of the same dangers as barbiturates, which is why most are now controlled substances or no longer available on the market. The image here highlights the historical packaging and how these drugs have been associated with both medical use and abuse. Here, we see the key drug interactions involving barbiturates and their clinical significance. First, barbiturates significantly amplify the effects of other central nervous system depressants like alcohol, benzodiazepines, and opioids. This combination raises the risk of respiratory depression, which can be life-threatening. Next, these drugs induce liver enzymes, speeding up the metabolism of medications such as oral contraceptives, warfarin, and tricyclic antidepressants. This enzyme induction can reduce the effectiveness of these drugs, potentially leading to therapeutic failure. Barbiturates also interact with certain antibiotics. For example, they diminish the effectiveness of doxycycline and alter metronidazole levels, which may impact treatment outcomes. Additionally, barbiturates compete with theophylline and acetaminophen in liver metabolism, increasing the risk of liver toxicity due to this competition. Moreover, monoamine oxidase inhibitors decrease the biotransformation of barbiturates, raising the risk of overdose if not carefully managed by a physician. Overall, understanding these interactions is essential to ensure safe prescribing practices and effective patient monitoring. Here we see the key diagnostic categories from the DSM-5 related to sedative, hypnotic, or anxiolytic use disorders. This includes not just the use disorder itself, but also intoxication, withdrawal, and substance-induced mental disorders linked to these substances. Diagnosis requires that at least 2 symptoms occur within a 12-month period, which helps establish a consistent pattern of problematic use. It's important to note that tolerance and withdrawal symptoms support the diagnosis, unless the medication is being taken exactly as prescribed and monitored by a physician, which would be an exception. Additionally, the DSM-5 includes modifiers to specify remission status, such as in early remission, in sustained remission, and whether the person is in a controlled environment. These allow clinicians to provide a more precise clinical picture. One critical point is that withdrawal symptoms, like rebound anxiety, can sometimes resemble those seen in alcohol withdrawal, which means the diagnosis requires careful clinical judgment to distinguish these conditions accurately. Overall, this framework guides clinicians in recognizing and categorizing the complex presentations of sedative-related disorders. Here we see the profound impact the COVID-19 pandemic has had on mental health worldwide. Anxiety disorders increased by 25%, and insomnia became more prevalent during this time. As a result, there's been a noticeable rise in the use of sedatives and anxiolytic treatments. This surge, however, brings a significant concern: the potential for self-medication and misuse, especially with substances like barbiturates that carry a high risk of dependency. Understanding this trend is crucial because it highlights the challenges healthcare providers face in safely prescribing and monitoring these medications amid increased demand. The image here, showing a person gazing out with abstract virus shapes in the foreground, visually represents the lingering mental health effects of the pandemic. Barbiturates have played a significant role in the history of sedative hypnotic drugs, representing a major breakthrough in treatment. However, they come with serious side effects and a high potential for misuse, which has greatly limited their use over time. Pharmacologically, they function similarly to alcohol and possess a narrow therapeutic window, meaning the difference between an effective dose and a lethal one is very small. This makes overdose a critical risk. Today, their medical use is quite limited. Safer alternatives are preferred, but when barbiturates are used, it requires careful clinical judgment to ensure patient safety. From a public health perspective, many drugs introduced as alternatives have also shown risks for misuse, underscoring the importance of ongoing monitoring and supervision. Ultimately, the priority remains to choose safer options whenever possible and to closely oversee their use to prevent harm. Now we've reached the time for questions and discussion. I'd like to open the floor to any thoughts or inquiries you might have, especially around when barbiturates are the right choice in clinical practice. We can also talk about how to best manage patients who are at high risk of misuse or have withdrawal challenges. Additionally, we can explore alternatives to barbiturates and consider the policy implications that influence their use. If you need more information or want to dive deeper after today's session, I have resources available for further reading and my contact details for follow-up questions. Please feel free to share your experiences or ask anything on your mind.